Good evening. Welcome to the Adult Obesity Guidelines webinar series hosted by the Office of Lifelong Learning at the University of Alberta and Obesity Canada. My name is Denise Campbell-Scherer. I'm the Associate Dean for the Office of Lifelong Learning, as well as a Professor of Family Medicine here at the University of Alberta. It was my great pleasure to serve on the executive of the Canadian Clinical Practice Guidelines. The new Clinical Practice Guidelines are expansive, 19 chapters on a wide range of topics related to obesity diagnosis and management, weight bias, and more, all written by Canada's top researchers, health practitioners, and patient advisors. They're the first truly patient-centered clinical practice guidelines on obesity and the result of more than 3 years of hard work by our interdisciplinary team. Just before we begin, I'd like to go over a few housekeeping items. We acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. With regards to webinar housekeeping, if you have questions pertaining to technical Canada programs and services, please use the chat feature of the webinar located on the bottom middle part of your screen. If you have questions for our panelists, please use the question and answer feature of the webinar, located to the right of that black bar on the bottom of your screen. Our panelists will answer several questions following the oral presentation. Some questions may be responded through text in the Q&A window. You can at any point use the Q&A button at the bottom of your screen to submit questions. We anticipate that there may be many questions, so please review the questions that have already been asked to see if they're similar to yours and upvote those questions that you would like to have answered. We cannot guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be available next week. It will be sent to you via email to all of those who registered. This link is for your personal use and is not to be forwarded or shared. This activity has not been formally reviewed by the CFPC or Royal College. However, it is eligible for non-certified credit. MainPro Plus participants may also earn extra additional certified credits by completing a linking to learning exercise. Please contribute your experience with obesity management to inform our advocacy and programming. So while you're waiting or after the event, please take 5 minutes to contribute your perspective. We also very much are looking forward to your feedback on the webinar and suggestions of things that you may like to see in further programming. So it is my very great pleasure to introduce Dr. Sara Kirk. We're so pleased that Sara will be here this evening presenting on reducing weight bias, obesity, stigma, and discrimination. Dr. Kirk is a professor of health promotion and the scientific director of the Healthy Populations Institute at Dalhousie University. Her research explores the creation of supportive environments for chronic disease prevention. Using a socio-ecological approach, she studies how individual behavior is influenced by broader factors like income, education, and societal norms. This has included a focus on better understanding how weight bias and stigma influence health and healthcare provider practice. She has over 200 published papers and was named one of Optimyz magazine's top 100 Canadian health and fitness influencers of 2019. She is the lead author on the new chapter on weight bias reduction. So thank you so much, Sara, and I'll turn it over to you.
Thanks so much, Denise, for that lovely introduction. Hi, everyone. It's my pleasure to be able to participate in this webinar, along with two of my chapter co-authors, Jimena Ramos-Salas and Angela Alberga. Jimena is joining me for the Tuesday webinar, and Angela is joining me for the Thursday webinar. And the new CPGs are a major step forward in how obesity is managed in Canada. And I'm especially proud to have led the chapter on reducing weight bias, obesity, stigma, and discrimination, the inclusion of which is actually a world first in a CPG like this. It's important to note here that the guidelines were designed with people living with obesity involved in the entire process and to address identified patient care gaps. The guidelines are also a living document, and we will update them as new research is generated. So for this webinar, I'm going to go over what we mean by the terms weight bias, obesity stigma, and discrimination. I'm going to talk about why these are such important issues to address, given their prevalence and impact, and I'm going to go over the recommendations that we have made. Then hopefully we will have some time for discussion. So let's get started with what we mean when we talk about weight bias, obesity stigma, and discrimination. And I want to begin by noting that a major shift in the new guidelines is the way we use the term obesity to mean a progressive, relapsing chronic disease where abnormal or excessive body fat or adiposity impairs health. What this means is that when we use the term obesity, we are not referring to weight or size. We recognize that obesity is a stigmatized term. The guidelines use the term obesity because this is the medical term for the disease we're addressing in the guidelines, but we use it to specifically mean excess adiposity that impairs health. Of course, it's going to take some time for this new definition to become understood and appropriately used. So it should also be noted, while these guidelines are based on the best available science, much of the science available is still based on weight and BMI. We're advocating for a move away from those measures, but again, this will take time to translate into research and practice, and so it's up to us to help create that shift. So when we talk about weight bias, what we are referring to is the negative weight-related attitudes, beliefs, assumptions, and judgments in society that are held about people living in large bodies. These assumptions are then manifested as stereotypes or prejudice toward people who do not conform to our societal norms. Weight bias, in turn, can be explicit, implicit, or internalized, which means bias that is self-directed. Explicit weight bias is defined as having overtly negative attitudes towards people with obesity, whereas implicit bias is conceptualized as having unconscious negative attitudes towards people in large bodies. But these attitudes are ones that are not acknowledged by those holding them, even though they then shape the way that people view and treat individuals living with obesity. Internalized weight bias, or self-directed bias, is the extent to which individuals living with obesity then endorse negative weight-biased beliefs about themselves. And ultimately, weight bias leads to stigma, which in turn can result in exclusion, marginalization, and the development of inequities. As previously noted, weight or obesity stigma represents the manifestation of weight bias through those harmful social stereotypes that are associated with people living with obesity. Weight discrimination means the unjust treatment of individuals because of their weight. So now let's move on to the prevalence and impact of weight bias and stigma. And as I mentioned at the beginning, in considering the prevalence of weight bias and stigma, we do need to be mindful that the available data are based on obesity as defined by BMI, not on the new CPG definition of excess adiposity that impairs health. So much of these data are from the US and through the research of Rebecca Poole and colleagues at the Rudd Center for Food Policy and Obesity, who are leaders in this field. Based on BMI, the prevalence of weight discrimination has increased by 66% over the past decade and is comparable to rates of racial discrimination, especially among women. It's rampant in the places where we spend our time. In elementary school, children who have obesity face a 63% higher chance of being bullied. In our workplaces, over half of adults with obesity report being stigmatized by co-workers. And in healthcare practice, 64% of adults with obesity will report experiencing weight bias from a healthcare professional. And then the media has a role to play in all of this as well. And we are all familiar with the images that are portrayed in the media, where 72% of images and 77% of videos stigmatize people with obesity, according to the most recent media studies. And this has an impact on the health and well-being of people living with obesity. Weight bias, stigma, and discrimination have far-reaching consequences, and at the center of these are the health and social inequalities that people experiencing stigma are exposed to. These impact psychosocial health, social outcomes, healthcare delivery, and ultimately morbidity and mortality. And specifically, people experiencing weight bias and obesity stigma experience physical health consequences. You can see here that there are physiological mechanisms that may contribute to this increased risk to physical health, such as chronic stress, which can increase cortisol levels, and oxidative stress independent of adiposity level, and also increase the risk of things like obesity and diabetes. These can increase the risk of mortality. One longitudinal study has suggested that perceiving weight discrimination is associated with a 60% increase in mortality risk. In terms of psychological health, people who are experiencing weight bias, stigma, do experience psychological distress. That may impact things like their medication adherence. It can increase their levels of anxiety, and as previously noted, it can also lead to stress, but whether that be real or perceived. It also can lead to mood or anxiety disorders, things like eating disturbances, depression, anxiety, body image dissatisfaction. Weight bias internalization is also associated with poorer overall mental health scores and depressive symptoms. In terms of healthcare delivery, weight bias in healthcare settings can reduce the quality of care for patients living with obesity. That treatment, that people with obesity also perceive biased treatment in the healthcare system. These have impact on patients' engagement in things like primary healthcare services. It can lead to delayed help-seeking behaviour, which then in turn can cause challenges if a diagnosis is not made in a timely manner. And there's also research that suggests that healthcare professionals may be spending inadequate time with patients with obesity, actually avoiding bringing up that topic. In terms of social outcomes, things like antisocial behaviour, substance use, unhealthy coping strategies, and lack of support have all been described in the research literature. This may lead to things like poor educational outcomes, to impact on employment and career consequences, and also we've seen evidence of stigma actually contributing to challenges in things like accessing housing as well. So I think it's clear that weight stigma is a determinant of health, and it has individual health consequences and also public health consequences. In terms of the individual health consequences, we see things like unhealthy eating and lower physical activity levels in people experiencing stigma. There are challenges around psychosocial disorders. It may lead again to that stress-induced pathophysiology, and then again that substandard healthcare and decreased healthcare utilisation. From the public health consequence side, we see a real disregard in the narrative that's put out around the societal and environmental contributors to obesity. So that minimizing of the complexity of obesity into, just you need to eat less and move more, and really not considering those wider societal and environmental factors. It can impair obesity prevention efforts. If that narrative is so strong, again, that increases the blame and shame and stigma that that people living with obesity face. And then again, it can increase those health disparities and those social inequalities. So moving on to the recommendations, our chapter has 4 recommendations that really do address a need to support primary care professionals who provide care for people with obesity. Again, going back to that definition of adiposity-related health impairments. So our first recommendation, and absolutely key to reducing weight bias, stigma and discrimination in healthcare settings, is for healthcare providers to be aware of their own attitudes and behaviours towards individuals living with obesity. This is something that can be achieved by completing a self-assessment tool like the implicit association test for weight bias, and there is a link to this test in the guidelines. It's an online test that can be done for a whole multitude of biases, and it's something that I would absolutely strongly recommend that if you haven't already done it, that you do complete that tool. And there's a need for systematic education on weight bias and stigma in all health professional training programs. Ways that you can think about this, how you can check your attitude, are to ask yourself these questions. Do you assume a person's health characteristics, behaviours and abilities are based on their body size, weight or shape? If so, then you need to understand that people come in different sizes and shapes. Body size, weight, and shape are not directly associated with a person's health, work ethic, willpower, intelligence, or skills. Another question could be, do you think that everyone with a larger body size or a higher BMI has obesity and needs to lose weight? Obesity, again, is a chronic disease where abnormal or excess body fat impairs health. BMI is an indicator of body size, but not health. And not everyone with a large body size or high BMI has obesity. So that's a very clear change in the way that we conceptualize obesity there. A third example is, do you believe people with obesity are personally responsible for their conditioning? Many people think obesity can be controlled by simply eating healthier and being active. We see that all the time in adverts for diet products or fad diets. But we know that there are many factors that contribute to obesity, and many of these factors are beyond an individual's control, and we have to take that into account. Our second recommendation comes from our understanding that internalized weight bias has negative impacts on health-related outcomes. So it's important that all health professionals assess their patients for internalized weight bias. This is the bias that people hold towards themselves, as mentioned previously. And we know that that actually affects behavioral and health outcomes. Internalized stigma occurs when a person is aware that he or she has a stigmatized identity, and they'll apply those negative social stereotypes to themselves. These sort of things like, the ones that we commonly see in terms of stereotypes are that people with obesity are lazy or awkward or sloppy, they're non-compliant, and they lack self-discipline and self-control necessary to manage their weight. And that weight bias and internalization and self-stigma means applying those negative weight bias stereotypes to yourself and engaging in self-blame for one's weight status. So that's the sort of that negative self-talk that comes out. I am less attractive than most other people because of my weight. I feel anxious about being overweight because of what people might think of me. And so really understanding how that impacts people's ability to engage in management options, and how that makes them feel when they're coming into your clinic or your office is a key part of addressing internalized weight bias. And shaming, it pains me to have to keep saying this, because one of the more pervasive beliefs held by health professionals seems to be that shaming a person about their elevated weight will actually motivate them to change their behaviour. And shaming tactics are still widely used by healthcare providers, despite the evidence that they don't work, and may in fact cause harm. In fact, individuals with higher internalized weight bias report less weight loss, lower physical activity levels, higher caloric intake, and greater disordered eating behaviours. And those shameful public health messages that we see could inadvertently make the problem worse and harm those most in need of help. And we can only look to the UK in their current campaign, which is really, I think, exemplifying what we mean by this. Our third recommendation is that healthcare providers should avoid using judgmental words, images, and practices when working with patients living with obesity. And there are words that have been tested. Again, Rebecca Poole and her colleagues have done a lot of work in this area to really kind of understand, like, how do people feel about the words that we use? And things like heavy, chubby, obese, fat, or morbidly obese are considered to be less desirable. Similarly, they are considered to be more stigmatizing. They're also more blaming, and then words like unhealthy weight, overweight, weight problem, morbidly obese, and obese are also considered to be less motivating. So really, again, thinking about the words that we use and really changing the way that we communicate about obesity is a critical part of this recommendation. And patients who experience weight bias in healthcare settings may, as mentioned previously, delay or forego essential preventive care, things like breast or cervical or colorectal cancer screening, for fear of receiving disrespectful treatment and negative attitudes from providers. And the environment plays a critical role in influencing opportunities, benefits, and burdens of individuals within the society. So healthcare providers should ensure their clinical environment is accessible, it's safe, and it's respectful to all patients, regardless of their weight or size. We, again, members of the CPG team have developed assessments of clinical space, an assessment of clinical space. This checklist here is available again for people to use, and just thinking about things like, you know, as somebody comes into your clinical space, you know, what is the waiting area like? What are the reading materials? What is displayed on the walls? All those kind of things. Making sure that things like your washroom has a toilet that's the right size, or you know, a container that has a handle. Things like the weighing scales being of appropriate size, and the examination table being appropriate for somebody living in a larger body, having a step stool that people can use, the clinical equipment, you know, gowns being of appropriate size, blood pressure cuffs, tape measures, needles, etc. All these things are things that we can do to make our environments more supportive of people living in large bodies. Our fourth recommendation and final recommendation is that we recommend that healthcare providers avoid making assumptions that an ailment or complaint that a patient presents with is related to their body weight. Again, that's really coming back to that idea of reframing obesity away from being weight related to being, you know, that notion of excess adiposity that impairs health. And here's a few quotes from our research that, again, sort of really illustrates what we mean here. That often assumptions are made by healthcare providers when somebody comes into the clinic space. So in this case, and this is learning from some of the research that I've done, this patient talks about there being such a stigma that is reinforced. When I enter the health system, the first place I expect to talk candidly about my issue, I hear the blame. Well, you know, if you eat right and exercise, you'll lose weight. It's as simple as that. It's a simple thing. That's what I get. It's so simple. And the fact that, you know, what this patient is saying is that they weren't heard, they weren't listened to, they weren't given that opportunity to talk about what they were experiencing. And on the right-hand side, you know, this we know that weight bias negatively affects patients' engagement in primary healthcare through their perceived barriers to healthcare utilization, expectations of differential healthcare treatment, low trust and poor communication, avoidance or delay of health services, and this notion of doctor shopping. So, you know, if you don't get good treatment somewhere, you know, you'll be looking for another healthcare provider. And so really, again, recognizing that these are barriers are things that we can really do something about as healthcare providers. Okay, so to conclude, these guidelines are based on the existing science and clinical practice that demonstrates that adipose tissue or adipose cells can become dysfunctional and impair health. This does not mean that all people with excess adiposity will have health impairments, and that's an important distinction. Yet we know that weight bias, obesity stigma, and discrimination harms health and social well-being, and they impact healthcare delivery. So, it's really important that you do assess your own biases, be they explicit, implicit, and in the case of individuals with obesity, those internalized weight biases. Watching your language, using things like the person first language, so we're not labeling people by their disease. You know, we use that in other areas of the health system, and it's time that we did this when we talk about obesity as well. And changing that narrative that obesity is a lifestyle or a behavior choice. You know, we know that weight is not a behavior. And we also know that now, you know, the evidence is strong that obesity is a chronic disease characterized by abnormal or excessive adiposity that impairs health. Those simplistic obesity interventions and approaches, such as the eat less and move more mantra, are simply not enough. And obesity management should be based on the accepted principles of chronic disease management. Focus on health and quality of life, and not on weight. Understanding the perspectives of patients living with obesity is vital to achieving patient-centered care in primary care and improving health outcomes. And check those physical environments, make sure that they're accessible, that they're safe, and they're respectful to all patients regardless of their weight or size. And finally, the guidelines reinforce the need to start where patients are at and to focus on patient engagement, improvement in patient-provider collaboration, and focus on health goals. And that's really such a key part of what we've been doing in these guidelines. And you can find the full guidelines at this website address. And thank you very much. I'll throw it open for questions.
For today's panel, in addition to Dr. Kirk and myself, we have Dr. Jimena Ramos-Salas. Jimena has a PhD in public health with a specialization in health promotion and socio-behavioral sciences from the University of Alberta here in Edmonton. She currently works as the Director of Research and Policy at Obesity Canada. And Jimena also works as a research and policy consultant with the European Association for the Study of Obesity and as a technical obesity consultant with the World Health Organization in the Regional Office for Europe. So it's much later in the day for Jimena. Welcome, Jimena. And we'll move to the questions. So Carol kicked us off, and I think this is such an important point where she's making a point around the prevalence side, around the definition of obesity. And that word actually has a historic sort of use, and then the use that we're trying to push towards in this guideline, which is around that excess adiposity, that it is impairing health, and sort of that desire to see that shift very consistently, and that there is confusion with that. So when we look at that prevalence data coming from the epidemiology space, which is more on the BMI categorization population level, that can cause some confusion. So I'm just wondering, Jimena, Sara, if you have any sort of reflections on that and sort of the experience that's happened with the group in terms of navigating that shift and change that we're trying to promote with this work.
Jimena, do you want to take that?
Sure, I can do that. Thank you, Denise, and thank you, Sara, for a great talk. Yeah, so this is something that we have discussed extensively over the last 3 years as we embarked in the guideline development process. And we realized and recognized that the significant amount of data related to obesity out there is based on BMI and weight. In order for us to shift towards that new definition of obesity, which is focused on health, we need to start doing that research that is based on different outcomes, such as, quality of life, patient values, health specific outcomes, psychological outcomes, etc. And so we actually made that explicit ask in the guidelines, in the summary document published in the Canadian Medical Association Journal, that we need researchers to move away from that BMI definition so that we can actually collect that new data that we need to make recommendations that are not just based on BMI and weight. So I think, we recognize the challenge, but again, like Sara mentioned in her presentation, we made our recommendations based on the available existing evidence that we have in our system, as well as trying to be compassionate and trying to shift that narrative towards a more health-focused definition. In terms of the prevalence slide that we had at the beginning of the presentation from the Red Center indicating the levels of weight bias and stigmatization, a lot of those studies were mixed. Some of them were conducted with people who identify as having obesity. Others were based on studies that were just measuring obesity based on BMI. So the data there is mixed, and but we're starting to see a shift for sure. Definitely that's something that you can see in the chapter that where you can read the whole narrative of all the literature reviewed and how some of those studies are based on BMI, not just obesity as impairment of health.
Yeah, and I'll just add to that as well. It's almost cart before the horse kind of scenario here as well that we're dealing with, and I like to think that, with this chapter, we're actually putting a line in the sand in terms of how we do things moving forward, based on the fact, as Jimena says, this is how we've done it in the past. That doesn't, being able to actually acknowledge that maybe we didn't do it well in the past, and now we can change that, I think is important to recognize, and I've done it myself. I know that some of the language that I've used in the past, the way that I frame things may not have been helpful. But, we have an opportunity here to exactly do that, change the narrative and be part of that ourselves. All of you on this call, on this webinar, have that opportunity as we move forward.
Mm-hmm. Thanks so much, Sarah. And I just want to chime in on that as well, because in our office, we do a lot of work with health administrative data. And one of the things that I find really interesting is that when people do have lipotoxicity, so they have adipose tissue, which is depositing in the pancreas or in the liver and actually contributing to metabolic disease, et cetera, that's a really important aspect of chronic disease. And yet in our health system, in Alberta, we're actually not recording that as a parameter. So when we tried to do population work, we weren't able to use our health administrative databases because it wasn't there. So fortunately, the Canadian Primary Care Sentinel Surveillance Network does capture actual weight, as well as other criteria that we would use in a staging system like the Edmonton Obesity Staging System. And there's other staging systems to help us be able to understand and distinguish a little bit between someone who happens to have a larger body but actually has no physical impairment, and someone who may have some really significant disease state that may be contributing to a potential for increased morbidity and mortality, where perhaps a different conversation would be helpful and beneficial. So so that shift, it informs what data is actually collected and what's paid attention to. And so it'd be great to see this as we move forward, to have more nuanced data to be able to do those sorts of distinguishing characteristics to really get at the elements around health. Now, there's a related excellent question. Thank you so much, Evelyn. So she's commenting about the Healthy at Every Size movement, which absolutely we find really compelling, and a lot of that data informed, especially in the primary care chapter. That folks in that community have some angst with the guidelines because they feel that obesity is not a disease and bariatric surgery is not a cure. And Evelyn's sharing that she works with patients who are thinking about having bariatric surgery or who have had bariatric surgery. And so she's wondering about how we can support and unify our practice. And this is just such an important question, because I think it gets really into this comment that we're just talking about, which is how do we actually define obesity? And we would agree that bariatric surgery is not a cure. Bariatric surgery is a treatment that's one really important treatment in a lifelong approach to a chronic disease, which takes a life course approach. So Sara, Jimena, what's your thoughts on that based on your review of the literature and your understanding of these different shifts and elements that are going on in our community?
If you want, I can start, Sara.
Sure.
So I would say that, in the last couple of slides of Sara's presentation, the focus was on patient-centered care. And I think that is a theme that is very strong throughout the guidelines. And that is the position that we should all be taking when working with individuals living with obesity, or individuals who identify as having obesity or who are seeking treatment for obesity. Obviously Sara discussed, some people with obesity having internalized weight bias and how that causes them feeling uncomfortable with their own bodies, etc. But if a patient is coming to seek obesity treatment because they have impairments related to their adiposity, then I think the first most important thing that we can do as healthcare professionals is to take that patient-centered lens and to listen to the patients and to understand their experiences and their context and really start from there, as opposed to having our own preconceived notions about what patients need and what patients should have. I think that's the first fundamental principle that we should engage in, but I welcome also Sarah's and Denise's input here as well.
Yeah, thank you. And again, I'm going to use the words of my my colleague and co-author or author on the guidelines, Dr. Michael Vallis, who I actually see is on the webinar as well today. Michael, talks about, again, as a group, how we recognize that fat cells are not inert. They do contribute to disease development. We cannot ignore that. And I think that's always, I'm firmly and strongly believe in the importance of the health at every size movement. I think it's it is a very important movement that we have to recognize, how that is shaping the narrative and will continue to shape the narrative. But I worry that it doesn't always take into account those environmental aspects that are challenging us, that health disrupting environment that is making it hard for all of us to maintain a body shape or size that prevents us from developing ill health in the future. So it's, and I think the language that I've heard Sean Wharton use is around elevated weight, or again excessive, that the wording that we're using in the guidance, excess adiposity that impacts health. That's what we're talking about here. We're talking about there being a health risk in some cases, and so we have to be mindful of that. It's something we have to think about, and I think every single person who is involved in these guidelines recognizes that as a challenge.
Mm-hmm.
But I'm interested in Denise's, Denise.
Yeah, thanks, Sarah. So, as a family doctor, who does research in this area, one of the things that we did in one of our trials was we had a large number of primary care patients. And we asked them, we said, what do you want? What would be helpful for you? And one of the things that was interesting in that study was every single patient said, I want to have a conversation. I want to be able to have a conversation, a healthy conversation, a person-centered conversation that's focused on me, that talks about my life, my health. And that was just really important lessons for us from our patients. And when we look across Canada, fewer than a quarter of patients report ever having a conversation with their healthcare provider about their weight. And yet it worries a lot of people. A lot of people are trying to find help for it. And so one of the target audiences for these guidelines was primary care providers. And what we're hoping to do is help empower people to have the knowledge and skills to be able to have those conversations that are supportive and evidence informed, and to be able to help people with questions that they have about their life and health. And that's one of the things that we're trying to do. And of course, we had patients involved with every aspect of these guidelines. The patient group was involved in everything from day one. And we're really, really happy about that, because we think that helps keep it real. And so, so I think that that's just my 2 cents about that. Anybody else have any comments on that? And so, we have a comment here from Michael Vallis, who's one of the chapter authors for the behavioral chapter and a member of the executive, who's participating today as a participant. And his comment is that I completely agree with Sarah. The health at every size has been trying to protect the dignity of individuals. And these new CPGs are trying to do the same thing. So he hopes this will allow for common ground on this issue. And the main difference we can examine is fat cells as disease contributors. And that's one of the things I find fascinating, is that since I was in medical school 20 years ago, we've actually discovered that adipose tissue is not inert, that it can become lipotoxic. and that actually important things like activity can help improve that. It's got nothing to do with a person's weight. It's got to do with where those toxic adipose tissue cells are depositing and what they're doing. So fascinating area. Thanks, Michael, for your comment. So let's pivot to Veronique, who asks a really important question that actually, Sarah, I was having as well on the slide. So we saw a number of words that were considered non-judgmental, or sorry, that were judgmental, but what would be a good way, as per the patient perspective, to actually talk about this when they're worrying about their weight?
Again, I think this is the continuation of the conversation that we've just had around, the thinking of it either things like elevated weight, which is a more neutral term, or just talking about excess adiposity that's impacting your health. And I really like that language, because it's, again, it takes it back to health, not weight. It's going to be hard. We've used this language for a number of years. It's going to be quite hard to sort of shift it around, but it starts with one person, and it starts with each of us making, committing to doing that, and asking, how, what words do you use? How do you feel about your health and your well-being, and making it that conversation.
Mm-hmm. And Jimena, you work with WHO internationally. One of the things that we've learned in our work is that in different languages, so in some languages, there's actually not even a word for obesity. The word doesn't even exist. So, in the work that you're doing with WHO, do you have any sort of thoughts on this topic as well?
So that has come up in WHO as well. And even here in Sweden, the word obesity is not really used. They use the word fetma, which means adiposity. And so I think there's a lot of different terms and different cultures and languages and how we frame it. But I think the fundamental idea is that these guidelines frame obesity as a chronic disease. And the standard approach to speaking about chronic diseases is using that person-first language approach. And rather than saying an obese person, we say a person living with obesity, or a person affected by obesity, or a person with obesity, just like we wouldn't say a cancerous person, or a hypertensive patient, or a diabetic patient. So I think just out of that is the fundamental principle that I think we can agree internationally, that a chronic disease should not define the person, and that whenever we are talking to a patient, we should put the person first and the disease second. And so rather than using labels like obese or cancerous or hypertensive or diabetic, we talk to the person and refer to the person and then the disease.
Mm-hmm. Yeah, no, that's wonderful. Thanks. Such a rich conversation in our Q&A, and Lucia makes the point that it would be great to have a resource of suggested words. And one of the things I just wanted to echo with this is that this guideline is intended to be a living document. And it was a massive amount of work to do the initial one. And so the idea is that we don't do that again, that we build upon what's there and shift and change. And there's space for all of us to contribute to keeping that document alive. So I don't know if there's such a resource, Lucia, around suggested words. I think Jimena, just correct me if I'm wrong.
There is one, if you Google Obesity UK, so our colleagues from the United Kingdom have recently published a language matters briefing and policy document. So if you Google Obesity UK, this is a patient-centered tool that was developed for patients and for the general public, but it was designed to focus around language and the idea that language does matter for patients, and that it's important for us to be wary of our language. And so if you Google Obesity UK, you will find that language matters document that I'm referring to that may be helpful.
And that sounds, in the spirit of a living document, it sounds like we should have a link.
Yes, I agree.
Yes, so that's my vote. Okay, and thanks so much, Lucia, for that. I just want to make sure that there's a few questions here that link together. So Donna and Limisi have sort of related questions. So Donna was asking about whether there'd been studies that have focused on broader determinants of health, patient-centered care, research survey questions that would be relevant, strength and equity-based use to adapt for researchers that are engaging in obesity and community-based and led research. So the answer to that is yes. Sarah, I'm sure you can chime in a little bit on that one.
Well, actually, I was thinking that Jimena, having recently, I mean, this is a big focus of your PhD, wasn't it, Jimena, the sort of equity lens. If you probably have a few more on the tip of your tongue.
I think in public health, so we live in the world of public health, and we work on population-based outcomes and population studies. And, you know, sometimes I think we forget that populations are made out of individuals because we're looking at those big sample sizes. But I think it is a strong, like the focus of my PhD was how we can shift that narrative in public health and to move away from that language that frames obesity as an individual responsibility, like Sarah was talking about, and also move towards, you know, focusing on improving the health of populations without having unintended consequences, such as contributing to more stigma and weight bias in our society. So language is one part of it, as well as, you know, how we frame obesity. So for example, when we have a public health intervention that is focusing on promoting physical activity or promoting healthy eating, you know, having outcomes that are outside of weight or BMI would be more helpful to encourage the whole population to eat healthy and exercise, because we all need to eat healthy and exercise, not just people living with obesity. So when we frame those interventions as obesity interventions, we tend to contribute to that bias and stigma. So I think that's, from a public health perspective, we do need to shift that as well, and think about how our population-based messages impact the way that individuals interact with our messaging.
Mm-hmm. Yeah, and actually that's just even at the individual level in practice. You know, we would say that a person who has a BMI of 26, but who has excess toxic adipose cells in the liver contributing to NAFLD, or in the pancreas contributing to diabetes, that they actually have obesity. They have obesity cells, adipose cells, where we do not want them. So so it's really getting away from BMI, and that's very relevant for different ethnicities as well. Donna, in the work that we're doing with different communities, we're taking more of a pure qualitative approach to that. So not so much surveys, but more interviews and focus groups, etc. And sorry, I'm going to pronounce this incorrectly. Limisi is contributing that she just completed, or he just completed, a PhD in Nigeria and West Africa, and this is really fascinating because in those cultures, you know, being larger is desirable and beautiful, but this need to shift to the health element, because there could be concerning elements such as diabetes, etc., you know, is really important. And so I think that just echoes what we've just been saying here. So thank you so much for that, and congratulations on completing your intervention study for your PhD. So Veronique is commenting back, that's the person who initiated some of the conversation, where she's talking about wanting to use the word obesity just to focus on the fact that it's recognizing it as a disease on its own. And I agree with you, Veronica. I mean, I think the key thing is, as Jimena was highlighting, the person first language. So in much the same way that perhaps when we started out in practice, we may have called a person, you know, a diabetic or a schizophrenic, that we move away from that language and speak about people with diabetes or people with schizophrenia or people with obesity. Is perhaps a helpful reformulation. But yeah, I mean, we think that word, when it applies to what we're talking about, which is excess adiposity, which is causing physical or metabolic harm to the person, that's concern to the person, then in that setting that it is a chronic disease. Anybody have any thoughts on that, just to round out that part of the conversation? And otherwise we'll pivot to our last question. Okay, so Paula comments that she concurs that providing patient-centered care is most important for providing healthcare for people with obesity, listening and understanding the determinants of health that impact the patient. Unfortunately, this practice takes time and is a barrier for implementing this practice. Do you have any current billing codes for providers and clinicians? Do you have suggestions or perspectives in overcoming this barrier? Yeah, so perhaps, guys, I'd like to take that one.
For sure.
If you go, yeah, if you go onto the webpage, and Melanie, perhaps she can in the chat box add in the link. But if you go into Obesity Canada and type in 5AST, you'll go to the 5A's team program. And that is a body of work which has been about trying to tackle exactly this issue. And we've created, we did a longitudinal study with people where we were working to create a primary care intervention that was focused on these elements and that was doable, which involved interviewing people and then having them keeping living journals in their life over several months, re-interviewing them repeatedly to try to understand what were the elements of the consultation that helped them the most with shifting. And then coming out of that work, we work with a human-centered designer to create tools and resources to support the training of that approach. And you can get your initial consultation down to about 20 minutes. In the US, the Centers for Medicare and Medicaid have had a billing code for obesity that does allow for a little bit of a longer initial visit. In Canada, that's highly variable across different jurisdictions. And that's something that we'd really love to see advocated for more. So for example, in Alberta, there is a chronic disease code that one could use, but it doesn't actually start until a person has a BMI of 40, which we think is really a challenge because people may want to have that conversation long before that point. So I think billing codes are probably a little bit beyond what we can talk about here, but as far as suggestions and perspectives, I think if you look at that section of the Obesity Canada webpage, you may have some thoughts, and lovely to hear from you about any ideas you might have as well. So guys, I think that that's 10 o'clock, so we should round up. Just thank you to Sara and Jimena and to all the team at Obesity Canada and Lifelong Learning for putting on the event. We would love your feedback. So on your screen, there's a link in your browser or the Scan Me code or a live link in the chat box. If you could take a couple minutes and give us some feedback, we would really appreciate it. Additionally, if you're able to contribute your perspective to the SenseMaker tool, we're trying to get a little bit of a perspective across Canada. Veronique has a question about the implicit association test. Do you guys have a quick suggestion on how to get that? I think you can get it straight from Google, yeah?
It's actually in the chapter. It's referenced in the chapter. If you go to the weight bias chapter on the guidelines website, you can find the link there.
Oh, perfect. Thanks, Jimena. On our panel today, in addition to Dr. Kirk and myself, we have Dr. Angela Alberga. Dr. Alberga is an assistant professor in the Department of Health, Kinesiology, and Applied Physiology at Concordia University in Montreal, Canada. Her research program focuses on better understanding of how societal, school, and other broader institutional factors influence weight-related issues, including obesity, eating disorders, physical inactivity, and weight stigma. She co-authored the weight bias chapter of these new 2020 Canadian Adult Obesity Clinical Practice Guidelines. So welcome, Angela, and thank you so much for joining us this evening. And thanks to the colleagues who've started us off with questions. And Stephanie Bertani got us started with a question about tools to evaluate weight bias in web and print resources. And she asked whether we have general advice for developing web and print resources on weight. So Angela and I have added some comments to the chat box. And I think that's a great topic for us to kick off our discussion. So Sara, when you're reflecting on places that you might direct people for resources, where might you suggest people go?
Sorry, I muted myself.
Mhm.
Yeah, I think the link there in the chat box chat box around the obesity action is one place. Also, Obesity Canada has a whole load of resources on their website that actually deal with this, and images that are non-stigmatizing. So it is a tricky one, because I can even be talking about ways of trying to do this, and we still see the same sort of thing. I'm just thinking of a recent interview when we talked about the guidelines, and I was literally on the screen watching these stigmatizing images passing by, and I actually called it out. I actually said, this is what we're talking about when we're talking about weight stigma. And so, I think that's another thing that we can do is call it out. But it's also, there are resources out there, and I think we just need to think very carefully about how we do that. And actually, even in the question, Stephanie, the sort of developing web and print resources on weight, I think again, focus on health, taking the conversation back to health behaviours rather than weight, is also key to this. I don't know whether Angela has anything else to add to that.
Super, thank you so much. And just to clarify to everybody, under Q&A, it's under Q&A under the tab. That's where all the things are being placed. So the chat, as we said before, is for administrative issues, and all the questions are in the Q&A tab. And this one's under the answered box. Don Hatnaka also added a link to the Obesity Canada resources for People First Language. Okay, so we have several questions here. So Veronica has a really important question, which is, what do we do when we encounter weight bias and perhaps stigmatizing talk in our clinical environments? And particularly in this case, she's highlighting working in an obesity clinic. And I'm just really curious, Angela, what would you think about that, Sara? And how might Veronica think about that and respond to that with her colleagues?
That's a great question. Thanks, Veronica, for bringing that up. This is something I think that's very challenging for many of us working in any healthcare setting. It's not an easy conversation to discuss. It's not something easy to discuss, especially with a coworker, when you clearly notice that there's, weight bias attitudes and beliefs about people living with obesity, especially when you're working in a setting that works a lot with those patients. So recognize that it's not easy, but I think a place where we can start is expressing concern. And I think by saying that, you show sensitivity, that it's not a battle that you're going to be, upset about or show anger about, but I think it's important to just express concern firstly. So maybe by just addressing it with some questions, by first saying, I've noticed that you spoke this way about a person living with obesity, and I was just wondering, how come you think that? Or is there something that we can discuss a little bit further? Because I've actually learned quite a bit about how prejudice can actually be sometimes harmful to people living with obesity, especially coming into a healthcare clinic. So I think by posing some questions, expressing concerns that it could be harmful to patients or even behaviors towards a patient, I think is a good starting place. And then you can also follow that up by saying there's resources available, or even providing some of your knowledge on the topic that you've learned from some of these webinars, or even looking at the clinical practice guidelines. I think showing clinical tools and showing these guidelines would also be a good place to begin by, just expressing that this is a common issue. Many of us have biases, and it's not just this one particular coworker who may have these types of attitudes. That actually is quite common, but it's important to just acknowledge that we all have biases and that we can realize them, be aware of them, actually do something so it doesn't affect our behavior and how we treat people.
Super, thank you, Angela. And Sara, did you want to weigh in on that one?
Oh, I think that's absolutely spot on, Angela. And I've come across this a lot as well, and I think that the goal is really, if you can bring those guidelines into the discussion, thinking about, just, you have to do it in a sensitive way, of course, but just, when you say things like this, this is how a patient might feel, just it's an art, of course, to try and bring these up. But the more we talk about it, the more we actually expose this as behavior that, we don't want to necessarily see, the better really for the patient.
That's really super. Thank you. And so Michaela and Cheryl are building on that question and really wanting to explore strategies and tips for helping patients assess their own internalized weight bias and stigma. And Cheryl highlights that in many of the patients that she's treating, they've been hearing negative comments about their weight for many years. And that sometimes it's hard to convince them that it's not wholly in their control. So, if you're working with people who are, have internalized this, what kind of things do you think might be helpful, or in your experience would be helpful for Cheryl and Michaela?
Angela, do you want to try that one?
Sure. Sorry, I was actually just, I was looking up the weight bias internalization scale so I can submit the link to that questionnaire online. Yeah, so just to quickly answer, I think one of the questions was just to figure out whether or not patients also have internalized weight stigma. Mm-hmm. First of all, that is quite common. And what I'm going to do is I'll send the link as soon as I finish trying to answer this question. First of all, I think it's important to just recognize that, we live in a weight bias world, and it is really quite common to adopt many of these societal beliefs and biases about ourselves and towards other people. So just recognizing that, being aware that it is quite challenging to stay away from those societal prejudices, and to just recognize that that's difficult in itself, and that may actually take quite a bit of work working with perhaps a psychologist or anyone else who may be able to provide more advice on body image related issues, other issues related to mental well-being, because internalized weight bias does have a relationship to body image disturbance and other psychological health issues. So I think that would be a good starting place. And I think to assess internalized weight bias, that can actually be done in a clinical setting as well. If that's a resource that your clinic or healthcare setting can provide, perhaps you can ask a questionnaire, and I will send that link off. It's the weight bias internalization scale. There's actually different versions. There's one version that can be assessed for patients living with obesity, but another questionnaire can actually be used for people of any body shape or size. Of any BMI, because weight bias internalization, we know it exists among people of normal weight and underweight as well. So it actually doesn't just affect people living with obesity.
Yeah, and I'll just add an example of a conversation I had with an individual who has struggled with his weight for a number of years, and this is actually a person that I know through the work, this sort of work. So, but not in a clinical setting. I just know him as a colleague, really. And he talked about how, for him, the shift in definition to obesity being excess adiposity and a chronic disease really, excess adiposity that impairs health, and also to considering it as a chronic disease, really helped him to overcome some of his own internalized weight bias. And I think, again, this is why, this is the motivation behind this chapter, is really, again, we shine a light on these things. We're drawing a line in the sand. This is like moving forward, we do things better and we help people, and we hopefully begin to reduce the number of times we're going to see this.
Mm-hmm. No, I think that's really interesting. And as you said, I mean, we've got this so entrenched in our current society where people are getting constant messaging about, you know, what is beauty. But beyond that, also, people are often shamed and blamed for perceived differences, physical differences of many different kinds. And this has a horrible effect on, you know, self-esteem. And, you know, we certainly see that a lot with young people, where they will come to clinic and really be not feeling good. And so really trying to think about what's going on in people's lives, meeting them where they're at, and trying to respond to things where they've actually had a lot of success, things where they are having a lot of achievement, and then working to try to really help people, you know, see that their own worth and power. And one of the things I've also observed is that sometimes when people have been sexually assaulted or sustained, you know, have experienced abuse, perhaps over longer periods of time, some of these disorders on their body shape and size can be quite tricky. And I think that that's really an opportunity to recognize that these folks really benefit, as you said, from psychological counseling and support to really unpack what's been going on with them. And that can really help people move into a different space. So that's just a clinical piece of it. So Carfu is building on that and wondering about what do we do with learners, and you know, should we be doing something before people go into clinical settings? If so, what could that be? And what kind of programs could exist for that? And is wondering about, you know, using implicit association tests and things like that for that purpose. Has anyone encountered anything like that, or have any comments about strategies that might be effective?
Absolutely. I actually run a course at Dalhousie for, we have an interprofessional health education program, and I run a course on interprofessional client-centered approaches to reduce weight bias and stigma. We make sure that we mix up with multiple, you know, different healthcare providers, students, and we actually, one of the things that I get them to do before they begin the actual course is do an implicit association test. We also get them to reflect on their own sort of behaviours, and then they obviously do an interprofessional scale as well. So we measure their understanding of interprofessional education. We deliver that module entirely online now, and it's actually been incredibly helpful. And we actually, I'd like Angela to jump in on, because Angela and her colleagues have done I think it was a systematic review, wasn't it, Angela, which actually helped to kind of get some sense of what are the things that we need to be doing when we're either training or trying to reduce weight bias and stigma. So the sort of core components of training, and I actually embed that into my training package as well, and have found that to not only help reduce, it has reduced weight bias. The research that we've done thus far, I haven't had it published yet, but it does demonstrate that these students do improve their attitudes, and also have come out with much more positive attitudes, and hopefully that would translate into behavior as well.
I'm sure everyone would be so interested in that. It'd be great to get a link to that, Sarah, for people that might be interested. Angela?
Sure, yeah. I don't have a link for it, unfortunately, but I can certainly, if anybody's interested, drop me an email and I'll be happy to share the sort of a summary of what we do.
Yes, thank you for that question, Carfu, and Sarah. I think you really expressed that this is so important to actually do these types of screening and assessment at the beginning, because so often we have so many of these biases ingrained in us, and I think it's really important to do these types of assessment to become aware of our biases and attitudes towards people with obesity. I think the implicit association test is a good one to start because it's free, it's easily accessible online. You can easily get that right off of Google. So that's a good place to screen allied health students. And I think as an example too, similarly to Sarah, with all my graduate students that start in working in my research lab, we also do this type of screening test and questionnaire to first assess our attitudes before they even begin any type of research in my lab. And I know Dr. Mary Forehand does this as well at the University of Alberta, we actually both do a similar type of bariatric sensitivity training, where similarly to Sara, we do a kind of shortened course or workshop with our students before they start in our labs, just about these types of issues and about these biases, how common they are, talk about prevalence, definitions, concepts, also assess our attitudes and beliefs through many of these questionnaires. Not only do we assess anti-fat attitudes, but we also assess things like causes of obesity to really understand what students already think about what causes obesity, and if they can actually think if other factors actually influence obesity other than just individual behavior. So that's a good way of also determining if there's a baseline level of weight bias in some of these students. So these types of things are really important, and doing these types of sensitivity trainings before people get into clinical placements, I think, is a really good thing to do.
Mm-hmm. Yeah, and just to normalize it, I mean, I think in our society, many of us have some intrinsic weight bias. And when you do the implicit association test, you may be surprised by your results. And that is because we've been acculturated in the society in which we live. And so it's tricky to change intrinsic. We can certainly become increasingly aware, though, and we can work to try to shift that and shift our understanding. And I think one of the things we've observed in the work we've done with training of medical residents and interdisciplinary team providers, as well as Institute of Professional Development for physicians, is that, you know, as people become more aware of the complex pathophysiology of this chronic disease, and more aware of the elements that are actually beyond people's control, and more aware of the fact that there are effective treatments for this chronic disease, it really helps open people's eyes to the fact that this is not a choice. A person's weight is not a behavior, it's not a choice. And that can really help people shift a lot. We do in our courses some optional bariatric simulation suit experiences. We've had people do narrative reflections on that experience, and it's been really powerful to help you know, people have some insight and understanding about this. So I certainly don't think we're going to have a situation where we will solve the problem, but we can build awareness of the problem. And in much the same way that we're doing very similar things for, you know, increasing awareness around racism and other kinds of issues, it's the same thing. And that's something that we all just need to learn how to do better. So Lori has a question, and she is wondering about if you identify again that you've had weight bias in an individual and you want to help people in developing their skills to provide obesity management, you know, are there other places for education and skills building for people to be able to do that shift? And we may have covered some of this in our answers, but does anyone have anything else they'd like to add for Lori?
I'll just jump into this. I was just kind of reflecting on the balanced view resource, actually. So if any, I'm not sure if anybody on the webinars are familiar with this, but this comes as a training program actually from BC. So it's literally balancedviewbc.ca. And it is about addressing weight bias and stigma in healthcare. It's something that I think remains offered for free, but I haven't checked lately on that. That might be a resource that is worth looking at. But in terms of actually not, I think the question was, you know, you might have those beliefs and you can still support somebody. I think, yes, you have to, you know, you have to, I think we all have to reflect on our own biases and with the best will in the world, you know, even if you work in this field, you may still, you know, because it's so powerful, the societal pressures and narrative that's out there, I think it's hard. You have to keep checking yourself. So I think all of us probably can relate to that in some way, shape or form.
Mm-hmm. Absolutely. So Alk has been patient, has a question around building on from that, around specific clinical counseling skills that we would recommend providers train in or work on so that counseling can be done in a non-judgmental manner. Such an important question.
Mm-hmm. Oh gosh, I wish Michael Vallis was was here to talk about this one. Motivational interviewing is the thing that kind of really springs to my mind as a way of approaching that. But again, we have resources. The Obesity Canada 5As, for example, I think is and again, Denise, you could probably speak more to that as well as a clinical tool. Really helps to guide you through that sort of, you know, that therapeutic relationship and how to start having those conversations with people.
Mm-hmm. Yeah, I would echo that. So I think if Alpha, if you check out the Obesity Canada webpage, and in the in Google, if you just type Obesity Canada and then 5AST for the 5As team, you'll get a page of oodles and oodles of tools and resources for primary care. And you'll get a suite of tools for supporting the clinical consultation in primary care. We've done a lot of work on that in terms of trying to understand what are the elements of the clinical consultation which are helpful for people and which help people shift. So one of the things we recognize in primary care is that only about a third of patients at any one point in time are actually ready for shared decision making and at a point where it makes sense to them in their overall life to really engage. But collaborative deliberation is an anchoring structure that that fits in, and it's really about seeking to help people understand what's going on with them, if that's something that's interesting and the priority for them. So we usually start with the importance of asking permission, and this was highlighted in the guideline. Asking permission is the most respectful and important thing to do because it just gives the person permission to say no, that that's not something that they want to talk about today. And in our research, sometimes people will come back a couple months later and say to the nurse or colleague, whoever's seeing them, you know what, I'm ready to talk about that now, because it is a really difficult topic for people to speak about. So asking permission to discuss it, and then listening first. So understanding briefly from them what their perspective and their story is really important. And then when you have more time, so negotiating for time, not trying to cram everything into a 10-minute visit, ask permission to have a separate visit to talk about it and sit down and talk about it. And the first part of the tools is understanding where the person's at in their physical, mental, emotional, spiritual health, understanding whether or not they have a functional goal, something that they really want to achieve that matters to them. And that's a good starting place. And then the next part of the assessment is understanding weight and health. And when you listen to that story, you identify successes and you identify challenges. And when you identify those strengths, it's heartbreaking, you know, in some of our interviews, when we identified the strengths and afterwards talked to the people, they said, you know, I didn't realize I had strengths, but invariably people have overcome amazing things in their life. And they have some current challenges. And then you use that together to explore where they might want to go in terms of their planning and their work. And so that's actually the stuff that we offer courses in. But if you just look at the materials online, there's videos, the tools are all there, they're all free. You do have to register, but they're free. And they work. So that might be a place to get started. Angela, did you have anything you wanted to chime in on that?
Oh, I think that's great how both of you answered. I don't have much to add. The only thing that I think I might just say is I think a lot of my counseling psychology colleagues might actually say that they approach some of these conversations with a social justice lens, because really weight bias is, you know, violation of human rights and it's harmful. So I think that coming from a place of social justice and recognizing that weight bias is a manifestation of social inequity and they experience inequity in so many realms of their lives, I think it's important to keep that in mind in many discussions. And like Denise and Sarah said about all the resources and asking permission to start at the beginning is just really important.
Mm-hmm. And hidden in the guideline under supplemental materials, Appendix 2, there's a really nice graphic that walks through the overall patient arc, and does have QR code links to some tools and resources. So Julius has a question about internalizing of beliefs that may begin in childhood with messages from parents or healthcare providers to children who may be outside the standard norms of current growth curves. And so is wondering about clinical approaches to help children. And this is such an important question. Of course, we're talking about the adult guidelines here, but I think it's so important. We should try to give a little bit of a point on this, because it sets everything up for the future, doesn't it?
Mm-hmm. I'm happy to give this a stab with a big caveat that I'm not a pediatrician, but I do work in children and youth in the school setting. So, and I will say one of my studies that really kind of underpins my understanding of this subject area. When I talked to, we did in-depth interviews with people living with obesity who were trying to find support for their concerns, and really a lot of, you know, when you unpack what they believed about obesity and about their own kind of journey, a lot of what they talked about was things beginning in childhood, being different in some way, taller, you know, or just out, exactly as it says, you know, outside those standard norms of current growth curves. You know, that was enough. And the way that was approached would really, you know, set them on a journey that literally lasts a lifetime. And I think it's really important. I think one of the things that there are pediatric guidelines going to be, they're under development now and will be coming out. But, you know, I think what we're talking about in the guidance is around that importance of framing any discussion around health and not weight, you know, recognizing that we all need to eat healthily and be more physically active, but that we also all live in this environment that is health disrupting. And I deliberately use the words health disrupting because, you know, often you'll hear the words the obesogenic environment, but that my challenge is that actually that makes it sound like, you know, that's the end game is obesity, when actually it's challenging all of us regardless of our body shape or size. So it is a sensitive issue, and I cringe when I hear, again, my home country of the UK talking about weighing kids in schools. You know, it's just such a horrible thing to even be thinking about. And we know that you know, an ill thought out comment can literally set a child on a path to an eating disorder, or to further challenges around their self-esteem or whatever. So I think we just have to really recognise those things, and again, the framing of health rather than weight, I think is the absolute first step there.
Yeah, I've added a couple of links on the Q&A to Julius's question under answered. Sorry, I was trying to fuddle around with trying to figure out how to type those in, but the Holland Bloorview group at the Kids Rehabilitation Hospital, so Amy McPherson's team, has done a lot of work on fostering positive weight-related conversations in children. And then Stasia Hatanakis from the Children's Hospital of Eastern Ontario has that link there to the Meant to Prevent, which is the type 2 diabetes prevention initiative for children and youth, which is also a bunch of tools and resources. And both Stasia and Amy, I believe, are working on those pediatric guidelines that are coming down the pipe. But I just would recommend those two sets of resources around having conversations with kids. And it's really difficult clinically, Julius, you know, and sometimes there's real mixed messaging. I mean, I had an exclusively breastfed infant who's 5 months of age coming to clinic with mom worried about obesity because they were told that they were off the growth curve. Well, just very beautiful round baby who's exclusively breastfed does not have a problem. So people get confusing messaging, but sometimes when kids do have a problem, you know, being able to have that conversation with parents is really sticky and challenging and difficult. But again, that asking permission and building on great relationships that you already have. And it can be really helpful. And also remembering kiddies who are under 2, if they're really shooting off of the curves, there are occasionally genetic problems. So sometimes we do actually have to identify those kids and get them referred to peds endo. That's really unusual, but it does happen. So if you see a little one under 2 really shooting off the curve, you know, think about a referral, because there may be something else going on. And Angela just shared a resource. Angela, do you want to comment on that?
That's perfect, Denise. You beat me to it. I was just going to talk about the Bloorview Research Center too, and Amy McPherson's group. They developed this amazing resource manual. They consulted several patients, several families. It's evidence-based as well. They did a lot of searching of the literature to provide this research, this PDF. And here I just put the link to the PDF that you were alluding to, Denise. And I think it's a really good place for healthcare professionals to consult, to think about these sometimes difficult conversations that you might have to have about weight with families.
Mm-hmm. Wow, yeah, no, so important. Well, I think we're coming up to the end of our time. It's flown by. Really want to thank all of our attendees for being here, as well as our participants for organizing, from Obesity Canada and from the Office of Lifelong Learning, and of course, Angela and Sara, and all of the 64 authors who contributed time and effort to the creation of these guidelines. We really appreciate your feedback. So as per last week, please go ahead and type into this browser and give us some thoughts about this webinar. We're always seeking to improve. The whole guidelines, I think, are like, you know, Leonard Cohen's album, you know, and the quote about, it's through the cracks the light comes in. So tell us where our cracks are so that we can improve. And also just really encourage people to do the Scan Me code and share your experiences with obesity management, really trying to build up understanding of what that looks like. So check out the SenseMaker tool and share some stories. And thanks everyone so very, very much.
Thank you, Denise.
Good night, everybody. See you next week for Arya Sharma and assessment.
Thanks, everyone.